welcome everybody to our first event at TECHLAB. My name is Nika. Good morning to those in Norway or other countries, and good afternoon to those in Singapore. I believe we have many guests and online from Singapore and Norway as well. My name is Nika, so I'm the Special Advisor in Innovation Norway. My area of focus is in healthcare. Prior to joining Innovation Norway, I spent about 15 years as an engineer and another 15 years in healthcare. So I have the privilege to actually design and also commission 2 hospitals in Singapore, mainly Khoo Teck Puat Hospital and So I'm glad today I have some of my friends and leaders in healthcare here to share with us about hospital building design and also the future hospital innovation that we can look forward to. Yeah. So I'd like to start off with our ambassador, His Excellency Ivan Homer. I'll do a quick intro on our ambassador. His Excellency Ivan Homer has commenced his tour of duty as ambassador for Norway to Singapore since September 2021. A career diplomat, Ambassador Homer has been with the Ministry of Foreign Affairs Norway since 1984. Ambassador Homer was the head of International Department for the Norwegian Parliament until end August 2021. Prior to this, he was a special advisor and ASEM senior officer and special advisor on global health for the Ministry of Foreign Affairs Norway. Mr. Homer has served as ambassador for Norway to India, to Bhutan, as well as to Indonesia, Timor-Leste, and Asia. He has been the deputy chief of Norwegian mission in Beijing, posted to Washington, D.C., Rome, and Manila, and served as Navy officer. Ambassador Homer is married and has 2 children. Wow, he definitely has traveled the whole world. Okay, we welcome our ambassador.
Thank you so much. Yeah, thank you very much. So, dear organizers, speakers, and panelists, dear health partners. Yes, I would also say good afternoon to you here in Singapore and good morning. I hope you had your first cup of coffee in Norway. I know it's still early in the morning and maybe it's a little bit colder too than we have here in Singapore. It's great to see all of you. Either you are here or you are on the screen. So I'm delighted to take part in the first TECHLAB webinar. So I would like to start today with congratulating Director Paul Kastman and his team at Innovation Norway here in Singapore, our good colleagues, because you had a vision and you have turned your vision into reality. Team Norway in Singapore is very happy to have this new and additional platform for working together to promote business cooperation between Norway and Singapore, and from Singapore also towards the rest of the region. So let's give them a hand of applause. Paul, you and your team. Here we are. Last week, on March 11, it was exactly 2 years since the World Health Organization declared COVID-19 a pandemic. 6 weeks after they declared a public health emergency. Since that, more than 6 million lives have been lost and at least 450 million people infected. All of us have had our lives changed, but some much more than others. So I know we share this wish that no one should be left behind in fighting the pandemic. As was said in the title, much has been lost. Lives, youth, old age, being together, livelihoods, the ability to travel, and so much more. But new things have also been found. New ways of living, new technology, new partnership. Albert Einstein was right in saying that in the midst of every crisis, there's great opportunity. The COVID-19 pandemic continues to impact health, social, and economic conditions worldwide. But there has been accelerated change in vaccine development and distribution, telemedicine, technology, remote work, and education. Public health gets much more attention in society. Increased international cooperation. Today, we also come together to share our experience from the pandemic that can help us in defining the future together to build a better tomorrow. To learn from top experts how to overcome the challenges of COVID-19. of future healthcare services and facilities should be equipped to become pandemic resilient. Dear health partners, the transformation we see in the healthcare sector cannot, however, not only be viewed through the lens of COVID-19. The healthcare system in Singapore has been going through substantial changes starting well before the pandemic. Technology was already playing an increasing role in local healthcare. There are several reasons for this, and they are interlinked and quite familiar to stakeholders in Norway. Singapore is also having an increasing elderly population, which is good, but it also means diminishing tax incomes and added public expenses for healthcare. An increasing pressure on hospital occupancy, with several hospitals in Singapore exceeding maximum capacity, and there's a need for more healthcare workers. The common challenges underscores our joint need for innovative solutions to increase efficiency and capacity for smart digital solutions. Artificial intelligence and telemedicine are important to achieve this. The pandemic has amplified the need for innovative solutions. Similarly, in Norway, innovation and cooperation have paved the way for a modern, patient-centered healthcare system, as well as robust ecosystem for development of smart digital solutions. The Norwegian healthcare system has a strong tradition of data-driven innovation, an extensive cooperation across sectoral boundaries, and a patient-centered approach to care and to treatment. These values together provide us with a unique platform to address healthcare challenges. Last year, a report by the Commonwealth Fund evaluated the healthcare systems of 11 high-income countries. Singapore was not among them. The report ranked Norway, the Netherlands, and Australia as the top 3 overall. Particularly 4 areas distinguish this country from the others, such as the United States. They provide for universal coverage and remove cost barriers. They invest in primary care system to ensure that high-value services are available in all communities to all people in the same way. They reduce administrative burdens that divert time, effort, and spending from health improvement efforts, and they invest in social services, especially for children and working-age adults. Dear health partners, in concluding, as COVID-19 pandemic has shown us, there is no nation with a perfect health system. Healthcare is and will remain work in progress. Only by learning from each other are we able to constantly move forward towards optimal health for all people at the price that a nation can afford. With this, I thank you for your kind attention, and I wish you a very fruitful dialogue today. And I'm very happy to be here on the TECHLAB. Thank you.
Thank you, Excellency. Next, I'd like to invite Paul Arne. Let me make a quick introduction about him. Paul Arne has been the Director of Innovation Norway, he's achieved my post, since 2018, and is on the board of Nordic Innovation House Singapore as well. He has previously spent 8 years in China, so be watchful, he actually understands Chinese. He was in China working for Innovation Norway as well, and the Norwegian Ministry of Foreign Affairs, covering the energy and environmental sectors, with a particular focus on offshore wind, circular economy, and CCUS, as in carbon capture, utilization, and storage. As part of this work, he managed the Norwegian Energy and Environmental Consortium in China. He was part of the team setting up the Norwegian Consulate General in Guangzhou in 2008, and he has also spent 2 years in Nepal working for the International Labour Organization. He has a master's degree in Chinese economics from the University of Oslo and the London School of Economics. Paul, please.
Okay, so now I can remove the mask, and I forgot to put on my contacts today, so it's very foggy when I'm wearing the mask. I'm very happy that I can actually take it off. Thank you so much for that introduction, Niker. Allow me first to express a special thanks to our supporting partners at this event Ambassador Homme and the Norwegian Embassy, as well as the NBUS, Norwegian Business Association here in Singapore. I'd also like to extend our thanks to our friends at SingHealth, the Norwegian Directorate for Health, Lærdom Medical, Roommate and SpeedDoc. So by means of introduction, for those of you that are not too familiar with Innovation Norway, we constitute the science and commercial section of the embassy here, as we do in several other locations around the world. We are an agency under the Ministry of Trade and Industry, as well as under the Ministry of Regional Development, which means that we also have a presence in all parts of Norway. We are essentially an important instrument for the Norwegian government when it comes to innovation and also to grow industry and companies and so on back home. And to give you a more familiar reference point here in Singapore, you could say that we are very much like a combination of Enterprise Singapore and the Economic Development Board. Now, healthcare is a space that we've been working in for the past couple of years in Singapore. In fact, one of the first partners we worked with here was Singapore General Hospital, starting back in December 2018. At that time, we engaged with Kenneth Quek, Jeffrey Guay, and the organization transformation team to better understand some of the pain points that their hospital was facing. Following this interaction, we identified relevant stakeholders in Norway, and we set up weekly virtual pitching sessions for the team at Singapore General Hospital. This culminated in a visit to Singapore in March 2019 of 10 Norwegian health tech companies. Looking back over the past couple of years, I guess you could say that Singapore General Hospital was a bit of a pioneer, setting the trend for virtual pitching or virtual meetings before it became an actual trend. The delegation visit to Singapore in March 2019 built a lot of interest on both sides, and that actually led to the two largest hospitals in Singapore visiting Norway in the fall of 2019. So Tam Tok Seng Hospital, as well as Singapore General Hospital, then visited Norway, and there was meetings at various hospitals back home in Norway and so on. Then when 2020 rolled around, we suddenly found ourselves in an increasingly digital world with no travel whatsoever. That hasn't stopped us from bringing Norwegian stakeholders to Singapore, albeit virtually. In fact, we've had several programs over the past couple of years exploring digital health solutions and COVID-19 relevant solutions and so on. Some of these activities we've done with the other Nordic countries. And this brings me over to the second point, our new tech lab. Around us, it seems that the pandemic is subsiding or becoming endemic in most countries. However, I firmly believe that virtual meetings and digital interactions are here to stay and will complement physical meetings and interaction going forward. We've seen that the technology works. We save time and costs. And less travel also has clear upsides when it comes to sustainability, which is an increasing focus for everyone. However, we should make our virtual meetings and digital interaction as optimal as possible. That is one of the goals of our new tech lab. Here we can invite local hospitals for virtual site visits to hospitals, research institutions and companies in Norway. We will use virtual reality technology to allow local stakeholders here in Singapore to meet up with counterparts in Norway on our VR platform and have technology demonstrated in 3D. We will also use the space for training workshops and studio quality hybrid events, sort of similar to what we're doing here today. So we are very much looking forward to exploring this with our partners here in Singapore and in Norway in the time to come. And I would also extend a special thanks to Nikur, who's been the head honcho for getting this up and running and for realizing the vision that Ambassador Homme was referring to. So I'd also like to give the word back to him, but also give him a hand for all the work he's done.
I'm looking forward to a pay rise pretty soon. Like what Paul mentioned, I think this is a very interesting, for those who are not aware, actually this is a hybrid webinar. That means we have speakers who's on site, we have audience on site. We also have speakers and audience also online. So we are trying to mix these two together. And because we believe moving forward, we never know how the situation will change. We believe the new life will be quite a bit of hybrid. That means we cannot rely purely on physical meetings. So we are trying to bring these two together. Thank you, His Excellency and Paul, for the opening addresses. So next section, we will have two keynote speakers, one from Singapore and one from Norway, right? So for Singapore, we have Prof. Lee. Prof. Lee is currently the Deputy Group CEO of Regional Health System, Sing Health, and where he actually leads population health efforts to enable residents in Eastern Singapore to keep well, get well, and live well. He also chairs the planning committee for the upcoming Eastern General and Community Hospitals. So that's a very new project, which I think is going to be ready by 2030. Right. His past appointments include CEO of Changi General Hospitals and Deputy Director of Medical Services for Health Services and Health Performance in the Ministry of Health, where he actually led the strategic development and improvement of health services. Prof. Lee is an adjunct professor at 3 institutions of higher learning. That's Salisbury Hock School of Public Health, National University of Singapore, Duke NUS Medical School, and Singapore University of Technology and Design. He was a member of several international committees under the World Health Organization, International Hospital Federation, and Joint Commission International. Prof. Lee co-edited Singapore Healthcare System, What 50 Years Have Achieved in 2015, and contributed the chapter on strategies for health services in the 6th edition of the Oxford Textbook for Public Health in 2015. He has also published and presented in international journals and conferences respectively. So we are glad to have Prof. Lee today with us to share with us his experience. Prof. Lee, please. Thank you.
His Excellency, thank you very much and also for inviting me for this session. So very good afternoon to all in Singapore, and a very good morning to our friends in Norway. It's a privilege to be able to share, and I think this is also an opportunity for me to learn from the experience from both Singapore and Norway. So as the title today, Lost and Found, I will get into my presentation, and I think that various people have quoted this, right? That out of adversity comes opportunity. But in terms of turning adversity into opportunity, I think, and in trying to reimagine the new normal, I like this diagram from that Peter Senge gave about the double loop learning, right? Because as we try to think of the new, what are the next things that we need to do, quite often we jump straight into the strategies and try to get the results. But when results don't work out, we keep focusing on the strategies when actually what we needed to do is actually to look at the assumptions, right? Have the assumptions changed? And I think the pandemic has changed quite a few of the assumptions that we are working with. And therefore, it helps by looking at the assumptions in terms of the care models, in terms of the infrastructure, in terms of how we interact with people, that will inform our strategies, and hopefully we will get improved results in terms of better outcomes for our patients as well as for our population. So what I will try to do today is to define some assumptions, examine some of them, and also try to challenge some of them as we move forward, and not call the double loop learning. So the first assumption is, what is our first line of defense in terms of any healthcare issue, right? And from the pandemic, what we learned is that the first line of defense is actually the population. The healthcare system, in particular the hospital, is actually the last line of defense, right? Because if we put the hospital as the first line of defense, we will get overwhelmed, because there is only a certain limited capacity, and especially in the current wave, where many of those who fall ill have, especially with the high vaccination rates, for example, in Singapore, where the disease is mostly mild and can be managed at home through what we call a home recovery program. We are recognizing that empowering our population, empowering our residents, empowering our patients make the big difference, which is why firstly is how do you keep wealth yourself, how mental wellness, and also in Singapore, the messages that has gone out, and also equipping our residents with the necessary tools, which includes giving out masks, giving out hand sanitizers, reminders on safe management measures, as well as also giving out the pulse oximeters. Right? When do you go? If your oxygen saturation is fine, you're feeling well, you can stay at home. But if it starts deteriorating, so that only those who really need whether to go to a doctor or go to the emergency department or get admitted, do so. And that's at the health protocols. I think as we evolve, we went into our Singapore the 1, 2, 3 health protocol as to what you can do. And this I think contributed significantly to our ability to manage the pandemic. Right. So for quite long we have been I think in many messages, we have been talking about empowering our residents, empowering our patients, and the pandemic has really brought this to the front and the criticality of doing that as the first line of defense. And then the next thing is that we have also in Singapore and used the word right-siding of care. Right? I think in various other jurisdictions, you have some variant of that, right? To have care delivered in the most appropriate setting. And we are also discovering that the importance of primary care and anchoring care out in the community. And the key challenge then is how do you enable our providers out in the community to be able to do it? And in Singapore, a key component were our GPs, what we call our public health preparedness clinics. And these are the clinics that could do the PCR tests, they could do the swabs, they could also provide certain treatment, and just lately, our primary care clinics, in the selected clinics you have read in the papers, can now also give the antiviral drugs to help the patient. So we are finding that the first line of defense is our patients and our residents themselves. The second line of defense is actually our primary care providers out in the community. But what is needed is then a system for the patients to be able to find the clinic easily. Right? Because you could have all the clinics, but if they can't find, and when people get worried, they will run straight to the emergency department, which is a natural reaction. And at the same time, to work out the system such that when they go, they have they do not need to worry about the cost, but the key is to be treated in the appropriate setting. So these are things that, again, the importance of primary care. And the other thing that the pandemic has taught us is that we often say necessity is the mother of invention, right? But sometimes we forget that necessity actually has 2 other children that are less well known, or invention has 2 other siblings, and the 2 other children are acceptance and adoption, right? Because quite a few things which previously we may have thought, is less likely or it won't happen, but because of the pressure of the pandemic where we need to distribute the care and all those things which we thought were not possible are now possible, and in fact have become mainstream. Right? Things like work from home. I think previously we do have it in certain forms, or we have Zoom meetings. I think before that Zoom was already there, but it changed the way in which we say, no, we can't have such things, but now it has become like the normal, like what we are having today, right? So it's about the perceived usefulness and the perceived ease of use, right? Because we can't meet so much physically, and therefore it forces us to rethink and reimagine how we deliver. So I think as a topic, the lost and the found, these are certain things that we found. And what are the things we found is, one is reimagining care. I think one is this study by Baines. It has accelerated the adoption of telemedicine. Right? Telemedicine has been in existence for some time, but the adoption in various areas has been a bit patchy. Right? But with this, it has gone up. I think Serena will be able to share more about the work, so I will let her, as she's the more expert in this area, to share about that. And the other thing is also the importance of including an ecosystem to support telehealth, right? Because if we have telehealth services, but they still have to collect their medicine, that makes it inconvenient. Right? The patient will say, if I have to go out and collect the medicine, myself go to the clinic, I see the doctor and collect the medicine. So the medication delivery services were something that we had to put in place, and now it has become virtually second nature. So when I go to the outpatient clinic, I would just do what we call drop and go, right? You drop your prescription and then that could be one when you are on premises, or you could even order and do a renewal. And for SingHealth, we have this app, what we call the Health Buddy app, where you can renew your prescriptions online, and you don't even need, because it's all linked back to their records. So these are things that we have now put in place. And I think 2 years ago, they were not so mainstream, but today it becomes second nature, it becomes known to us. And the other thing that was what Changi General Hospital introduced, rehabilitation is something that we are familiar with. They have gone now into prehab, that even before you go for surgery, we do improve your status because it's shown that it improves outcomes. But that's one innovation. But the next innovation is actually having the prehab to be done at home, right? And this is, in a sense, like I say, required by necessity because of but at the same time, it has increased the acceptance because people may have concerns about traveling, getting out their homes, but now with this, they are able to do the exercises, and they found that the results of it actually does work, right? So these are the changes in the care delivery models. So what we are thinking is that going forward, one of the possible reimagination of healthcare is a bit like the F1, the Formula One, right? Whereby in a Formula One system, we have them going around the track, the cars going around the track at very high speed, and also the availability of the pit stop. I see the hospital, especially the acute hospitals in the future, as functioning as those pit stops, right? Where if you need a quick fix, which cannot be done out on the track, you come in, but when you come in, it is already, in a sense, already known what are the needs. So for example, in the Formula One, there is active surveillance as the car is moving around. There's telemetry, the data is transmitted about the car, about the driver, and they know the condition. And at the center, they also monitor other things, the weather and all this. I think you may have seen the video of the key decision that led one of the drivers to win the race because he changed the tires or he pitted at the right time. But these are things which today, when a patient comes in, unfortunately, sometimes they come in, each time they come in is like a new case. And in various systems, the patient is clubbed by one doctor, and then another person comes and asks the question again and again, and they get a bit irritated. Why am I keep repeating? But if we can have a situation whereby we already know what's happening outside, and the importance of knowing what is happening out in the community is what we call understanding our patients in their natural environment. Because the hospital, like it or not, is an artificial environment, right? I'm not sure about you, but for me, sometimes before I see the doctor, I will make sure that that morning I don't eat the sweetest food, right? I more relaxed, but some people get more agitated when they see, and then their blood pressures may not be the most accurate and all those things. So if we really want to have a better indication of how our patients are doing, it is in their homes. And that's the whole purpose, right? Because the purpose of healthcare is not to get people into hospital, but to enable our patients to enjoy life in the community as much as possible. So it's the active surveillance. Two is then there's also this analytics to pick up what is the noise and what is the signal, what is actually significant, so that key decisions could be made. And when the decisions are made, then it's a timely and targeted intervention, because the pit stop has gone into really a science where everyone knows what is their role, they know what they need to do, when they do it, and they can do it concurrently. I think this is a dream that we have, that when you come in, you keep, and especially in the time of the pandemic, where one, there's a pressure on the number of beds, and two, you want to reduce the dwell time in the healthcare institution, right? If you need to, first, if you don't need to come in, don't come in. Right? But secondly, if you really need to come in, can we keep your time in the healthcare institution as short as possible? And that is where what happens out in the community, preparing what is necessary gets us ready for that. And the third one is the resilience. I think F1 has built itself up that such that even when the car crashes or when it catches fire, the driver, fortunately, and not just because of fortune, but it's the science has gone into it, that the driver is able to be safely evacuated. So I think that's what I thought the healthcare system could be, right? Because life is won on the track, not but the hospitals function as a safety net as and when needed, and it plays a strategic role. So I think for healthcare going into the future, it is about the hospitals working in tandem with what is in the community, right? The first line of defense, our patients and our residents. Second line of defense, which is our primary care providers and the community-based providers. And the third line of defense, which is in a sense a safety net, then becomes the hospital. But the hospitals then play a very critical and very important role in this whole context. But in order for the hospital to play this important role, the hospital needs to ensure that it is resilient. And resilience also means that to be prepared for incidences which may catch us by surprise and which may result in certain destruction of the services. Right? So in terms of the infrastructure, how can we make our infrastructure to be more agile? And how can we make it to be more resilient? So one of the things that we are thinking about as we are designing a hospital is to how can we make it in terms of a more modular design. So it's a bit like the submarine. You know, in a submarine there is a compartmentalized such that even if there's a leak in one, they can actually seal it off, and the submarine can safely move until it gets to port and it's get refurbished or done well, right? So those are the things which we need to keep, because how can the hospital continue functioning even when faced with incidences or adverse events which may not be anticipated? So, for example, can we have it, a decentralized departments, maximum functionality, but with a common access to the key resources, right? Because while we want to compartmentalize, we also need to think about in peacetime, such that the cost is not too prohibitive. If we need to replicate all the operating theaters, it will be just too expensive. So then how to have individual entrances and the vertical transportation. So these are design features which we are considering. And also how do we enable quick conversion? And Singapore General Hospital, I think this came out in the papers, took it from the papers where Straits Times, portable chambers that convert wards and ICUs into negative pressure isolation rooms. So it's by adding on a component, what they call the SG Spark for the operating theater. By just adding on this, it creates like an antechamber that transforms it and could enable quick conversion into, and the pictures are here. And if you Google it, I think you can find it on the Straits Times. And the other thing that we also learn in terms of the resilience of our healthcare institution is the definition of what is an essential worker. Right? That's another thing that we have learned and another assumption that we needed to think about. Right? Often we say everyone is important, and in the pandemic, it really demonstrated the importance of everyone who works in the hospital. From the most senior person to the most junior person, everyone has a key role. And the unsung heroes that work behind the scenes, for example, our cleaners, right? For them to be able to clean the place quickly and to do it correctly, the right amount of disinfectants and all those things, gives a lot of confidence to the staff. Right? When the pandemic first broke, I was the CEO of the hospital, and each time when we had to manage some patients being infected, the thing that gave me great comfort was to know that the cleaners in the hospital are equipped and capable to do it, and they can respond in a timely manner. It gave me a lot of assurance. So these are, in a sense, the unsung heroes. And the other is the ops center, which coordinated what happens in the hospital. Because in a crisis, you have so much information, so many things happening. The staff are confused. Even the CEO is sometimes confused because there's so many things. But what we found was that the ops center became the single source of truth. Right? So instructions coming down from MOH, things coming in from the hospital, they are the ones who integrate it. And then we told our staff, what you listen to is the instruction that come out from the ops center. Even if me as a CEO issue it, you double check against the ops center because they will have the most current information. Because I cannot be there to keep sending it out. So even when I send things out, I do it through our ops center. But these are the people who actually work behind the scenes. In fact, in the crisis, they were working 24/7. And these, again, are essential workers. But sometimes we think of essential workers as doctors, nurses, allied health professionals. They are important, but this opens it up. And here is also our contact tracing team, the epidemiology and all those. That in peacetime, we think of them as what is their role, but in a crisis, they really do show for their worth. The other thing is also in a crisis is the need for technology to augment our workforce, right? Because even as our patients get infected, staff do get infected too, and that affects the absenteeism rate. And in addition to that, it's also about the having then to manage an increased workload. So you have this robot, the TEMI robot that allows teleconsultation, and also in the polyclinics, the robot that disinfects surfaces and things like that. So these are areas that we try to work with to augment our workforce. Right? And the other thing, I think this is a key area that has come out, which is join in work. Because I think the pandemic has added a lot of stress to already, in healthcare, it is a stressful environment, and the pandemic has added to it. So we have recognized the importance of ensuring that we take a very holistic view. So it's not just giving out care packs, but it's from the whole leadership structure, the processes that we put in place, the support mechanism that we put in place, the policies in how we manage that. So that is from the Institute for Healthcare Improvement, the framework, and we try to do that. And also in terms of our work from home and hybrid working. So we now have to rethink the way we configure our office, right? So if you are going into office to do work, which is just in front of the computer and typing away and you're alone, could that be actually done at home? Because it's maybe more comfortable for you. You have your drinks, you have your favorite snacks and all those things. Okay, we put on a bit more weight, but that's a separate issue. But then when you come in, is it then time for collaboration? But also to have like those boxes where you have can have private conversations. So we had to rethink the role of officers, right? So, and I think one key thing that the pandemic has taught us is that we need to work together. I think one thing that we really found is the importance of collaboration. And this was a chart diagram actually early in the pandemic where it was said all the agencies. So it's not just a whole of government approach, it's a whole of Singapore approach where they have the public sector, the people sector, and the private sector all coming together to provide this, right? And Straits Times in 2021 had this COVID-19 has shown what's possible through partnerships. There was Straits Times and our Ministry of MCCY, the round table, say when they were rising, more spaces were needed. A group of organizations came forward and they converted the expo into doing that. And the community spirit shines, is helping our migrant workers. So it's about everyone working together. And therefore, I think today's session is really I see as part of this process of collaboration, learning from each other, working together to address that common goal. So thank you very much for this opportunity to share and to learn from each other here. So look forward to a meaningful dialogue session. Thank you.
Thank you, Prof. There was a lot of information about Singapore. Next, of course, we move on to Norway because there's so a lot to learn from Norway. Dr. Johan, our original speaker, sent his apology. Unfortunately, yesterday he was tested COVID positive, so he has quite a bad throat. But nevertheless, we still hear from Norway because we have Dr. Ellen. Dr. Ellen is the Director of Global Health and Health Intelligence at Norwegian Directorate of Health. For those in Singapore, the Norwegian Directorate of Health is actually our equivalent of MOH. He's actually he's a medical doctor and a certified specialist in public health medicine in Norway and United Kingdom. where he has worked at national, regional, and local levels. Alan completed a PhD in obesity surgery at University of Oslo and subsequently a master's degree in public health at University of Cambridge. So Alan will be sharing with us online in this case. So let's sit back and welcome Alan.
Thanks very much. Hi, everyone. I hope you now can see the slides that I'm sharing on your screens.
Yes, well.
Okay, excellent. And I hope you can hear me. So sorry, Johan couldn't join me this morning, but I will take you through the slides that he has prepared. And I'm delighted to have the chance to be part of this very important conversation on building a post-pandemic future. I was sort of tempted to say good morning, but I think I should say good afternoon. And great to be here. So what I had in mind to go through, just a brief outline, is to first point to some of the features of Norway's health and care system, which is key to understand the response to the pandemic in Norway. And then I'm going to highlight some of the limitations of our system, or maybe I should say shortages in how we were prepared for the pandemic. Then I will highlight some of the developments that have been driven by the pandemic, which have also been touched upon by the previous speaker, and finally point to some challenges going forward. Okay, so Norway, as you may know, is a fairly small country with a population of above 5 million. We have a very scattered population compared to many other countries. There's organized in 11 counties and some 350 municipalities, which vary greatly in size, from down to around 2,000 inhabitants to the largest, which is the capital, Oslo, of around 700,000 inhabitants. So what we see is that most of the population, around 80%, live in what we define as urban areas. And you can see in this map that a lot of the population is sort of gathered around the coastal regions. What we see in recent decades is that a lot of young people especially move from the more rural areas towards the urban areas. So this means that gradually the rural areas will develop an older demographic, and it also becomes more difficult to recruit healthcare workers there. Now, in the pandemic, of course, it's also somewhat of an advantage to live in an area which isn't so densely populated because of the lower risk of spreading infections. So what we've seen is that Oslo has been the epicenter of the pandemic for large parts of it, and the more severe restrictions on social contact have been seen there as a result. So just to show you a little bit about how the services are scattered across the country. This illustrates hospitals around Norway, those with emergency services, and as you can see there are quite a few of them. So this illustrates an important point, which is that Norway has a quite decentralized healthcare service. You could maybe say that hospitals are semi-centralized, but I guess that is all relative. But certainly primary care services are quite decentralized. So the way this works is that each municipality has responsibility for delivering primary care services, including, for example, general practitioners, which are gatekeepers for the use of secondary care services in hospitals. This basically requires a referral from a GP. So healthcare services in the municipalities are ultimately the responsibility of a democratically elected mayor. Municipalities are also responsible for other services for their citizens, as well as emergency response across sectors. And all municipalities must have a medical officer with responsibility for infection control, which has of course been very important during the pandemic. So this slide illustrates in small fonts the sort of setup of the Norwegian health and care system, divided in different governance levels, from parliament, shown at the top, to the level of healthcare providers, shown at the bottom. I think to pick up on what the previous speaker said, maybe we should actually show the healthcare providers, the frontline heroes at the top when we make these slides, but will have to be for the next presentation. So as you can see here, the hospitals are owned by and are under the governance of the Ministry of Health and Care Services, with a more or less direct line through 5 regional health authorities. So it's easier to see a sort of clear chain of command here in the hospital sector in Norway compared to primary care. As mentioned, municipalities vary extensively in size, and as a result, they also differ in how they organize their services. And they're not directly under the governance of the Ministry of Health in the same way. Nevertheless, it's fair to say that the Norwegian health and care system is predominantly under democratic governance and control. There are some private actors, but these mostly operate within a public system. To the top right here, you can also see illustrated the Norwegian Directorate of Health. I'm just going to briefly explain what our remit is. So our mandate is to improve health of citizens and the community as a whole through activities across sectors and administrative levels. And we have these 4 roles shown here. An advisory role, which sort of relies on professional knowledge and technical support. We have also a regulatory legislative role. We have a role to implement national policies, and we have a key role in emergency response, where we coordinate a lot of the efforts across the sector. So we don't produce knowledge in the way that a National Public Health Institute would normally do, but we sit somewhere between them and help put the best evidence to use, if you will. We sit somewhere between an Institute of Public Health and the Ministry of Health. So just to summarize some of the key features or cornerstones of the Norway healthcare system is that we have basically high degree of health coverage, which is available to most citizens, some places for a small cost, but nevertheless available. Hospitals are government owned. Municipalities are responsible for providing healthcare to those in their locality, as well as emergency preparedness. So there is a clear responsibility which is allocated to various public entities as described in law, and there was also emergency response plans written up before the pandemic, as you would expect. Clearly though, even though we had plans in place, Norway has also learned some lessons during the pandemic, so I'm going to dive into those now and summarize some of the key ones. So here are listed some of the challenges seen during the pandemic. And I think what is clear is that some of the biggest bottlenecks and shortages that we have experienced were actually quite predictable. So we could have known ahead of the pandemic, if a pandemic hits, these things listed here might hinder an effective public health response to the pandemic. For example, general practitioners were already under a lot of pressure before the pandemic, due to aging populations with more chronic disease, new tasks shifted from hospitals, and so on. Similarly, we could have known potentially that the availability of qualified intensive care unit nurses could become a problem. So not only a challenge with having available sufficient ventilators to help patients with severe COVID-19 infection to breathe, but also the staff needed to operate these ventilators. And obviously the pandemic in itself also made it more difficult to rely on healthcare staff with a background from outside of Norway, both due to travel restrictions, but also staff preference to stay elsewhere. In terms of stocks of pharmaceuticals and single-use equipment, we had gradually reduced our stock over time, so that we didn't have large amounts of personal protective gear for healthcare personnel or other single-use equipment. It also became clear that we could not rely on markets to function in the way that they normally do. This was also seen, for example, in terms of getting access to vaccines. So I'm going to pick up now on some of the developments that we've seen during the pandemic. Obviously, the pandemic has affected our health and care systems in so many ways, and here are some examples of sort of health system innovations driven by the pandemic seen in the Norwegian context. So in terms of, maybe I put this top one here because of the organization that I belong to, but really a key feature for managing the pandemic is the improved speed of available data reports for crisis management. So I put real-time reports to government administration and services here, and real-time is sort of the improvement from, say, monthly or bi-monthly reporting to daily reports, which for all practical purposes is real-time. So this relates to, you know, identified cases, proportion of the population being vaccinated with 1 or 2 doses, quantitative and qualitative assessments of hospital capacity, primary healthcare capacity, etc. And this information was shared both with central government, with the Ministry of Health, and stakeholders across the regions as well. So this is a major development. One development which has helped track immune status has been the establishment of national records, which can sorry. Okay, I'll just carry on. I think maybe someone needs to mute. There was a huge improvement in the proportion of general practitioners, for example, providing digital consultations. I think before the pandemic, during a period of 3 to 4 years, some 15% of general practitioners were able to provide digital consultations, whereas after 3 months of the pandemic, 90% of general practitioners offered digital consultations to their patients. So really a big shift there. Another feature that we hear discussions around is task shifting. This was seen, for example, in the delivery of vaccines, where volunteers or other sectors were actually helping with the delivery of the last round of vaccines. One important development that I expect we will see more of it in the future is more widespread use of home diagnostic kits, which has become obviously very commonplace in terms of COVID-19, and people have become accustomed to this. Obviously, you need to have some good way of knowing, for patients to know how to respond to a negative or positive test, but this is an important development. We've had apps to notify people of possible exposure based on their location. We've tried out various mass testing regimes, and some hospitals have also looked at opportunities for more effective resource use, for example, single-use gloves as a result of high usage during the pandemic. So these are some important developments. Of course, being able to intentionally shift the focus of our healthcare system has both positive effects and negative effects. So, and when we focus on bringing the pandemic under control and providing acute services, there are also some unintended consequences. For example, there might be backlogs of elective surgery, groups that are hard to reach, maybe even harder to reach, and consequences from non-pharmaceutical interventions, such as school closures, can be particularly problematic for children and young people who are in a vulnerable context. So there are some things to look into here for those looking at service design. For example, how can we best track backlogs of services? This is done by regional health trusts in Norway. But how should you most effectively reduce it? And which groups should you target first? How do we best measure the health burden, not relating to the pandemic per se, that is more easily measured perhaps, but from results of how we manage the pandemics in different groups of society. So those are some examples. Also, there are examples of innovative approaches to how we manage with the post-COVID-19 condition, where there's presumably a lot of new information coming out in the coming months and years. So here are some examples of things that need to be done. So one example to the top left relates to how can we undertake research more effectively to learn more about long-term COVID-19 conditions. Are there any ways in which we can update clinical guidelines to reflect this new research faster than what we normally do? And how can we implement this guidance more effectively into clinical practice and increase the knowledge of healthcare staff? And not least, how can we more effectively communicate with patients to ensure that they can be reassured that they will improve with time, so that it will be more manageable to live with their conditions. And I think we've all seen how information systems have been vastly transformed during the pandemic, where suddenly it became commonplace that articles are published and widely available before they have undergone any sort of peer review, which is the common standard. So I'm moving to the last slide now, which is basically a summary of what I've gone through. We've spoken briefly about the cornerstones of the Norwegian health and care system. We've discussed some of the things to think about for the next pandemic for both the Norway healthcare system and others, and some of the things to think about going forward and some of the opportunities for innovation of services. So I'm going to stop there, but thank you so much for listening, and I'll try to be part of most of the session. Thanks so much.
Thank you, Alan. So we have heard from Singapore and both from Norway about the challenges that the healthcare system faces. So for those solution providers who are online or on site, if you find that you do have some solutions to all these problem statements, do get in contact with me, then I can do the link up as well. So we will online and on site, if you have actually some questions that you have in mind after hearing our two keynote speakers, you can actually put up on the chat, and then later at the end of this session, we'll look into those questions and try to answer them. If not, we'll follow up by email. So having here about the problem statement, I think what I want to showcase for the next session is about some of the possible solutions that has been implemented. So we have 3 use cases here, which we'll go through one by one. But first, let me invite from Norway, from roommate Sven. Okay, Sven will be sharing online as well. So let me do a quick introduction on Sven. He's actually an entrepreneur and executive within the care tech business with more than 20 years experience. Together with customers and health professionals, he has developed and deployed new solutions for municipal, home care, institutions, and hospitals, and experienced a huge growth and impact of new solutions in care work for the benefit of patients, employees, and the society at large. He's particularly interested in human side to implementing new solutions in care work. So let's put our hand together for Sven, and it's a very interesting solution indeed.
Thank you.
Yeah.
Yes, thank you so much, Nicker, and good afternoon, Singapore. Thank you for the invitation. I'm delighted to be with you from London, actually, where I'm calling from now. So it's quite early here. So I will show my presentation, and it's so, Nicker, that you will take up any questions, and
yes,
we go through them afterwards. Great, thank you.
Yeah, we'll do it at the end of it, at the end of the session.
Okay, yeah.
Good. Yeah, all good.
Yes, so I come from the company Roommate, which is located in Norway, and we have been in business for around 7 years now. So what we one of the things that we address is we look at the physical monitoring of patients, and as you know, from doing that manually, as most people do today, it does take up a lot of resources from more important tasks. And this is something that nurses strive with. They can be in the room and check in on the patient, but typically when they do so, there is actually nothing going on in the room. The patient is in his bed and everything is fine with the patient. But the minute the nurse leaves the room, then something might occur, like the patient has been woken up by the nurse's visit, he goes out of his bed and he falls over and hurts himself. And the physical monitoring of patients also causes stress and insecurity for the staff because they know that they cannot be everywhere at the same time, and they they are stressed by the fact that something might go on in the room and they are not able to care for the patient when it happens, or even also before it happens. And also the physical monitoring stresses the patients, of course. I think it's very clear to all of us that we don't really want people looking in on us while we are sleeping, for instance, if it can be avoided. And we have seen that physical monitoring of patients also means reduced sleep quality for the patient, which again subsequently leads to a slower recovery. And now all of this has escalated as well, because we have seen, of course, from the pandemic that there has been an increased number of patients. There is an increased number of safety precautions which the care staff must abide when it comes to protective gear and cleaning and so forth. The recruitment problems is known all over the world for health professionals. It's a global crisis, a global nurse crisis. I saw one paper called it in Canada. And it's a common problem also now that there is burnout and stress-related sick leaves among health professionals, which was bad before the pandemic, and it's even worse now. So what does roommate do? Well, we have this sensor that offers a remote and automated monitoring of the patient's room. It is located in the patient's room. It sits on the wall. It is a discrete and passive sensor that has been designed not to disturb the patient visually, and it's not something that looks like a camera, and it isn't a camera. It's just a square white brick-sized sensor. And what it can do, among other things, is that it can give an anonymized supervision of the room. That means that you can look into the room without the patient being compromised, the patient's privacy being compromised. And it can, among other things, also detect falls without the patient needs to wear any wearables. It doesn't have to have any equipment on him, and the sensor itself can detect if the patient falls. But it can also do a lot more, which I will come to very quickly. It's based on infrared light, and it is a 3D sensor based on infrared light. That means that we can detect a lot of movement and incidences in the room by itself. So while there are images available for the nurses when there is an alarm triggered or when they do a supervision of the room, those images are only visible to the care personnel at that moment. Afterwards, the images are not stored, but all the actions that the care staff has done will be logged. So what the sensor can basically detect is falls. It can detect if the patient leaves the bed. It can also detect if the patient sits up in bed, and that is one of the triggers that might indicate that the patient is going out of the bed and then subsequently falling. So for patients with fall risks, this is an excellent trigger to prevent falling. And as you will see later, we have excellent results when it comes to fall prevention from hospitals and care homes alike. The sensor can alert if there is an activity in the room when it's not supposed to be. If someone enters the room or leaves the room, it can tell you if the patient leaves his chair, if he tends to sit in the chair and sleep, for instance. That could be good to know. It can alert if the patient stays too long in the bathroom. It can detect if the patient shouts out, calls out for help, so the sensor can trigger that. And it can also detect if the patient is, there are no movement in the patient's bed, which can indicate, of course, that the patient is lying very still for a prolonged time, but it can also indicate that the patient has not actually gone to bed yet. So what it looks like when it comes to fall prevention is this is an image from our demo room, and it shows what I mean when I say it's an anonymized image. As you can see, there are no details from the room. The blue area here is the patient sitting up in bed. The orange area is the floor. So this is just colored by the sensor to make it easier for us humans to see the different components and the important components in the room. So in this case, there has been a triggered an alarm that the patient is sitting up in bed. And if this is a patient with a fall risk, then nurse staff can go into his room and help him out of bed, and even perhaps also calm him down and get him back to bed. So with this solution, you reduces greatly the need for physical nightly visits, and you can also talk to the patient via the sensor. The sensor has a two-way sound system, so that you can also, if this was in a private home, you could also ask the patient if everything is okay, and you can get his response. And maybe also in that case, you can remove the need to go home to the patient. It's a very easy to use and learn interface, and we have worked a lot with nurses and health professionals to be able to provide a solution that is very low tech to the care staff, but it's very easy to get the information that they need. So also for that reason, we have this overview screen, which gives the care staff an instant read of the status in all the rooms. So there are various symbols connected to all the rooms, so we can see that in this room the patient is sleeping, or at least in her bed. In this room, the patient is sitting in the chair. In this room, the patient is moving about, at least he's not in his bed or in his chair, and so forth. And there are 3 yellow alerts, which are not necessarily a critical alarm, but it's something that the nurses should be aware of. And then there is the red alarm. There is someone who has fallen in this room, and that should of course be tended to immediately. These alarms will also come to the nurse's phone or tablet or whatever they use as an alert system in their department. And then you can also add various active sensors to roommate wirelessly. So these are battery operated sensors. There are pull cords. You have your panic buttons, alarm, pendants or wristbands, motion sensors, a lot of different types of sensors that can be added to the roommate sensor. They are battery operated and wireless. So if you want to, for instance, in the bathroom, you want to put in a pull cord, you can very easily do that to extend the use and the service of the system. So this is what it looks like if you do a planned supervision. If you want to check in on the patient without the system having triggered an alarm, you can also do that. So you have several ways of doing that, or you can at least choose to use the anonymized view, which in most cases is quite sufficient and preserves the patient's privacy. But you can also open for a more detailed view of the room, which looks like this. So of course, this is not a camera, this is not a web camera, but it can produce a little bit more detailed images of the room if that is necessary for that particular patient. But this is something that the care professional and the staff must evaluate in each case, what kind of privacy level is needed. And as you perhaps can see, there are buttons here as well where you can also listen in to the room, and you can also set up a two-way conversation if that makes sense. So some of the experiences we have had with roommate. This is from a care home in a rather small municipality, local community with about 30,000 inhabitants. So they had a trial in a care home where they had 2 departments, one short-term and one dementia assisted living facility. And the dotted line here marks when the roommate sensors were deployed, and the columns here says how many falls there were subsequently. So as you can see, the number of falls were dropped quite significantly. And if we just do this very quick statistics based on these figures, in this particular home, they would actually reduce fall incidents by 168. And at least from the Scandinavias, we know that 10 to 20% of all falls actually lead to a serious injury like a hip fracture. So for this for this municipality, it's possible to save huge amounts of money and, of course, also human agony. But what is also perhaps the most important, and I really enjoyed what Professor Lee talked about when he said about the joy in work, because it's actually also possible to have technology help in work satisfaction. And and in this municipality, they asked the nurses, what do you think about the system? And they were actually very happy with it. They really want to continue with it. They see that it reduces the stress they experience in their work, and it simplifies the work. So these are great results, and this is something that the municipality has done on their own. We didn't even ask for this, they just sent it to us. And we also have a similar response from a hospital in Norway, where they also they eradicated fall incidents completely in this one ward where they had this pilot, and they are now increasing the use of roommate to the entire hospital. And so they basically, after they started December 1st last year with roommate, they have had no fall incidents in this hospital ward. And what they also have been able to do is that they don't anymore need staff sitting in the patient room during night if there is a patient with significant fall risk. So this, of course, is a huge money-saving system for them. And we also see that the nurses are very happy with the system. It frees up time for them to handle the acute patients, but also it says that, okay, this means that I can focus on important work during the night instead of going into patient's room just to check on them. So, for instance, administrating medication for the morning, they can do that unhindered and with full focus. The patient also sleeps better during the night, which also then subsequently leads to reduced fall risk and, of course, also shorter hospital time. So this is a typical, also a win-win situation with the use of roommate. So what we see in our, besides all of these functions, which is available in this one sensor that sits on the wall, we will also, in quite short time, we will add enhanced sleep analysis. It doesn't necessarily mean, well, that we can add respiratory analysis and that deep analysis, but we can at least say something about the patient's movement in the bed during the night, which might indicate some kind of deterioration or development in the patient's health. We will have better AI-powered decision support. That means that we can evaluate the patient's movement in the room, gait, and all kinds of things that might help the nurses to give have a better decision support, to maybe also detect dementia at an early stage. We have already an integration to electronic health records, patient records, so that is available, and also user federation for the users in the system, so that you don't need to have a separate user management for roommate. We also are integrated well, roommate is a part of the Sensor Group welfare technology and company, and we are also then able to integrate to many other solutions in the Sensio family. And we offer a very easy startup model for those who want to do the first pilots in Singapore. So it's for one department in a hospital that wants to test our solution. It doesn't need to cost anything for the actual sensors and for the training. The only thing we ask is that the hospital and the department allocate enough resources to do the training of the staff and to actually monitor if things are working. This is something that we can help you with. And when it comes to full deployment in a hospital or in a care home, we offer both a rental model or a buying model with a small monthly fee. So we are quite flexible in how the service is paid for. So yeah, I think I went a little bit over time there, Nicker, but at least I got through the presentation. So thank you so much.
Thank you, Sven. Yeah. Well, I just want to add on the Innovation Norway is here to really link up between Singapore and Norway in terms of technology and also knowledge sharing. So, and if I believe there's a lot of local hospitals, healthcare providers online as well on site. If you have any interest in roommate product, please get in contact with me. I'll link you up with them. So next, the company that I'm going to introduce is Ladell. I think everybody's familiar with them. So we have the sales manager from Ladell, Kenneth. So Kenneth has been working on the medical simulation industry since 2006. He's involved in overseeing the setup of training centers in major medical institutes, hospital simulation centers, laboratories in the Asia region. His experience and passion for learning has helped him in the setup of a number of successful simulation centers. Although high-tech simulation equipment plays an important role in a simulation training center, Kenneth also strongly believes that there is equal emphasis on the teaching curriculum, space planning, AV system, logistical planning, and hiring of good technologies. So we welcome Kenneth.
Thanks, Nika. So hi, I'm Kenneth over here. So I think my relationship with Nika is sort of a kind of love and foul also, because we used to work together quite a long time ago. So today on my slides, sorry, the screen is not on the front. Screen is not on.
There's Sven. Yep. Hi.
Nice.
Yeah.
Yeah.
Yes, it's not the lab on headquarters.
This is definitely not.
Yeah.
In the screen. Apology, there's some technical challenges.
Mm-hmm.
Just give us a minute.
Yeah, maybe when.
So while we're waiting, so Kenneth mentioned that we work together because I used to work in a hospital and Kenneth is actually my supplier. But Ladell is no stranger to many hospitals in Singapore. But Ladell does not just provide Medicine, and today he's going to share with us a lot of other technology, very interesting technology. And one of the very key one will be at the last slide, I believe, have a lot of great interest to everyone. This is something that we have partners together and we are actually collaborating with many other companies as well.
I think it's the main purpose of innovation.
Yeah. Thank you. Okay.
Thank you. Okay, the screen is up now. So hi everyone. Sorry again. Was the screen in front of me just now?
Ja,
Hi, I'm Kenneth.
Men jeg kan godt sætte dig jeg vil gerne sætte dig i kontakt med Glas.
We need to mute someone. Okay, now I'm back on track. Okay, so thank you everyone. I'm Kenneth here again. Right. So first thing I would just want to mention is that we are talking today about lost and found technical issues. Is it working now? Okay, so what we have really lost in this particular pandemic. So as a vendor or as a frequent visitors to the hospital or training center in Singapore, so these are the common sites that we see always before the pandemic. You know, the training centers is always packed with people, you know, medical professionals. Even in BLS centers, when you can see groups of 10 to 20 people gathering around the mannequins to do CPR training. Or even in the educational institute like NUS, you can see doctors or even graduates working on the skills trainer itself. And of course, having them all coming back together to do the briefing as a group. So these are the common sites, you know, when way before the pandemic starts. So when the pandemic hits us, I'll say that the next thing we face is, these are actually the real feedbacks from some of the user or even the user or even trainee that we face. So first thing, BLS training centers have been telling us that, oh, nowadays when I was training on my CPR, I can't do a mouth-to-mouth ventilation. No, this is things that I can't do now because of the pandemic. And within the same hospital group, there's no more traveling across intergroup medical facility. So this is also a create the hinders for all the participants that they can't cross over to other sites for particular training or even the teams training with other groups of people. And of course, with the pandemic's hits, of course, there's no more than 5 in the group for training, or even all this training have been shifted online. There's no longer any hands-on that they can do during the training. And all this, ultimately, of course, during a pandemic, everybody is overwhelmed by their work. They're not available to be trained on. They have no time to go on training. There's insufficient equipment that allows them to utilize or even bring it over to their own department for usage, right? And what we need to overcome. So during that time, we have been thinking around how can we overcome this? Because for medical professionals, I think the first thing they need is physical equipment. Ultimately, they need to be hands-on to the patient, and equivalents to our skills trainer or even equipment, they need to be hands-on. And of course, minimizing our training material handout, same things for the equipments and material. And there's a resources crunch due to more training sessions of the smaller group. Instead of training a group of 30, now you need to break it down to the groups of 5. And probably you need to train more than 5 sessions a day. And the other one is training interval lead time increases for sanitization, replacement of contaminated consumables. Imagine the time that was required for your simulation lab pathologists who need to do all this sanitization work. Additional minutes or hours were spent to do all this replacement. And they have a concern on, what about if I'm able to, utilize this part of the consumables? What about the next person? Will it be contaminated, or there will be risk of passing the virus over to the next person? Training will need to be performing hands-on. This is a basic requirement as a supplier or even educational supplier provider for us. Space planning to accommodate smaller group size. So our training center has always been designed to house 20 to 30 packs. Every training room is designed to house 5 to 10. So at this point of time during a pandemic, they are always facing this problem, having such a big space, but having such a small group that you need to run multiple sessions. What's next? Right? So how do ourselves adapt to all these challenges? Of course, using the first thing, the power of internet. We'll try to deliver our training through the internet, right? Produce affordable trainer. It means that it is not about the huge, expensive trainer that we're talking about. It is about something that is smaller, compact, mobile, that you're able to bring it home to use, or even bring it home that you can train remotely and to be able to be evaluated by your trainer, right? And the third point is strengthening of our existing e-learning platform. So e-learning is not something foreign to us. E-learning has been on institute for a long time. So I will say that definitely this e-learning platform has been put into a spotlight under this pandemic, when no one could go to their training facility, no one could go to the school or even hospitals. On the last point, ability to provide assessment evaluation from cloud. So this is something new that we identified as value for the faculty or even the trainer to be able to do an assessment remotely at their free time, because now there are so many sessions happening on each individual. So this particular assessor will be able to assess these training records, do its assessment, and provide the evaluation scoring to that performance of the user. Right, so what we have found. So one of them is what we call the RQI. RQI have been in the market for some time. So this is actually a mobile card that contains or even carries our CPR training models. So what's the difference between this and the conventional training center is that at the own free time of the individual, they are supposed to go to this card that have been deployed around the hospital or training facility. They no longer need to gather as a huge group, going to one particular training center to get their CPR assessed and even satisfied. So this RQI have been one of the solutions that have been proven very successful in the US. The other one is our modular trainer. So on the modular trainer that I'm talking about on the left bottom, it is a small trainer that is designed or even to make it more compact that the user could actually carry it home to do a hands-on training of their own leisure time without intercrossing or even meeting their peers. So this will help them to prevent any contacts, right? And of course, incorporating the SIM capture that we created for the cloud system, you can actually incorporate with this modular skills trainer that you perform all your skills, get it pre-recorded into your phone, and upload over for your assessor to do an evaluation, to do a scoring, or even to tell you how well you have done on your particular training. So all this can be actually done or performed at home. And the next one is vSIM e-learning. So this is the module that we are talking about that have been in the market for quite a long time. So this allows them to understand the protocol on their, of course, from the cloud, which is on their own personal PC, logging into the account and understanding the protocol for nursing. Right, so same thing as for the SIM capture system, this can be accessed by an instructor remotely. And lastly, the Anywhere system. So this is delivering the CPR training remotely by creating a virtual classroom, which allow everyone to join in this virtual place and perform CPR training on their own leisure time on the not exactly on the mannequin or simulator. You can actually do it on the pillow or empty bottle. So this allows to capture your motion of providing that part of the compression and give a scoring remotely through the cloud to that one trainer through the cloud, right? And of course, of all this, it has been the continuous improvement that we're looking at, because for us, Liddell, our main mission of helping save life have been driving us to be able to be more innovative in the way, working with partners, working closely with Innovation Norway to create a better solutions, to be provided during this post-pandemic time. I'll say in the future, MedTech, of course, moving into the cloud, we've been looking to a lot of those e-platform solutions that is effective or even helpful to healthcare in this healthcare industry. And last but not least, I will be talking about our innovation. So this is a slide that I promised Nika that we'll be mentioning about. All right, the consortium initiative that have been newly established between 3 companies. So this is of course Nika hard work to put us together to leverage our capability, or even to able to come in a consortium between Connexus, ourselves, Liddell, and Dossier. So we are building up a learning and competency tracking system, which hopefully we can pilot into healthcare industry and ultimately into the community as a full system solutions, right? And that's it for my presentation. Thank you.
Thank you, Kenneth. Yeah. So for those who are interested to know more about the learning and development ecosystem, again, please contact me. Yeah. So learning is actually, I believe, a very, very key component nowadays, especially with the COVID coming. We can see the tremendous pressure in sending information or educating or empowering not just the staff who are handling all the requirements from the Ministry of Health, but also the population. You can see the drastic change every day. It's so fast that it's quite difficult to cope. So being able to have that direct connection, which actually probably just mentioned, those apps that we have, but beyond that, what is behind the system to help us to send that information and that knowledge across quickly. But Liddell and the consortium here have the solution. Okay. So please stay online, because after this, we have some very interesting and challenging questions that I'm going to post to all the speakers individually later. But last but not least, let's invite Serene Chai. She's the co-founder and head of partnership and projects at SpeedDoc. At SpeedDoc, she works with major healthcare institutions for clinical validation of digital healthcare, creating consortiums with industry partners to provide enhanced medical care through digital means, and generally finding new and safe ways to enhance healthcare delivery through technology. She's passionate about making healthcare more accessible and causing relating to women and children. Catherine, please.
Okay, so hi, my name is Serene. I'm the co-founder of SpeedDoc. If you haven't heard of us, don't worry, you will know us by the end of my slides. Whoops. So, I'm just trying to shine a little bit more light on the context and shed more color, So when I was thinking about what to present during this presentation, I thought about, the pandemic, how life was before and how life was after. And something that was interesting was that it was just a few years before the pandemic that digital health was really kind of accepted in Singapore. And so for those of you who are not dialing in from Singapore, in 2016, I think the government changed the licensing in Singapore. So it changed from a premise-based license. So you hold like a hospital license or a clinic license. And they were exploring whether they wanted to license by service instead. So you hold a health screening license, or you hold a telemedicine license, or mobile medicine license. And so that's been pushed a little bit forward, but that was actually the basis of digital health in Singapore. That was also kind of where the idea of SpeedDoc started when I met my business partner, who is a medical doctor. And I think during the pandemic, it's very easy for everyone to say there's acceptance of telehealth, acceptance of digital health, because there's no really other alternatives. But something that I want to talk about later is the increasing sophistication that we're seeing, not just in telehealth, the use of telehealth and also the neighboring industries. And so I don't have it in this presentation, but we're seeing things like drone delivery of medication, right? In Singapore, we're kind of seeing that more in the maritime industry because of the protected airspace in Singapore. But we're also seeing sophisticated users of telemedicine. So we have very sophisticated customers who use it, for example, as a triage system, right? We have mothers who are calling in who say, my baby just ate one whole, tube of toothpaste. What do I do now, right? And they get medical advice from a doctor. And that wasn't really the first use case, right? The first use case is to diagnose a patient, treat a patient, not really for triage, but we do see increasing sophisticated use of digital health. And so that's what I kind of want to talk about today. So SpeedDoc, we're actually an app. You can see it from my later slides, but we have home doctors, home nursing, telemedicine, remote monitoring, as well as booking of ambulances. And you access us through an app. But what's interesting is not really the app. It's the number of services that we provide, that we can provide through a same location within the same company, right? And so when we think about health-seeking journey of a patient, we're not just thinking about them visiting the GP, right? A singular person also, gets sick enough to be hospitalized, or a sick person, one day wants to do a health screening, one day doesn't feel so good, doesn't really know what's wrong with him, and this person has family members and loved ones that they take care of. And I think that's very important when you think about digital health. It's not just episodic care, but it's the management of a system. And that's why we're trying to integrate, okay, a lot of buzzwords on this slide. So I'll go on to the next slide first. This slide. Okay. And so we're trying to integrate things like, remote monitoring devices, and when, we can put them on the EHR system. So for those of you who don't know EHR, that's electronic health record system. And what this does is that it actually augments, right? So I think some of the previous speakers talked about technology augmented medical care. And this is where we use technology to red flag patients. We use technology to, for example, look at trends and, alert doctors, and what it does is that it helps doctors make decision making a little bit easier for doctors to make decisions. So, for example, what we're trying to do is not replace doctors, but help them make better decisions, because nothing really can replace the human touch, especially when you're talking about doctors with 20, 30, 40 years of experience. We're just trying to make them make better decisions by using technologies to bring up the red flags and signposts. And now I just go back to my previous slides. Buzzwords on this slide. So I'm going to pick out the word decentralized, because this is the third time today you're hearing the word decentralized. I did hear it in the previous presentations. And so what we're trying to do is we think about a hospital, right? If a person is sick enough to be admitted into a hospital, we're trying to break down the medical care that they see in a hospital, and we're trying to replace that with technology at home, right? And we do that using clinical programs. So every morning, for example, with our partners, with major hospitals in Singapore, we meet with the doctors. We say, okay, this patient, this is how he performed last night. This is how we're going to treat him today. Is there any changes you want to do? And so we have this thing called a team meeting, and then we go ahead to replicate the care he would have in the hospital at home. So for example, if you were sick enough to be in a hospital, you probably would need a nurse to take your vitals, every hour, see how you're trending. And now we can do that with technology. So we're saving costs. And if you think about not just the out-of-pocket spend, we talk about total healthcare spend, we actually can do this for much cheaper at home. And so one of the major use cases actually, I'm not sure if European people view this the same way, but in Singapore, I think a lot of the elderly were very afraid of going to the hospitals, and that was actually exacerbated during the COVID crisis because what happened was that COVID restrictions prevented family members from visiting too easily, and a lot of elderly patients, a lot of the very sad cases, they passed away without seeing their family members or without anybody by their side. And so a lot of them started saying that, okay, we want to be at home. How do we be at home? And so we started trying to have a safe way to do that for our patients. And now I will just go through the little journey. So again, decentralization is not something that's unique to Asia, not unique to any of us. We're seeing news reports and research from around the world that is, espousing the benefits of decentralized healthcare. I will just go on to this thing that we trademark as HWARD. So H, it's a little bit of a marketing tactic, but H stands for hope, it stands for hospital, and it stands for health. That's everything that's important to us. And what we try to do is that we work with hospitals, we do patient recruitment together with the hospitals. We see who can be, we have very specific use cases for who can be treated and admitted in a certain way, and then we replicate the medical care at home. So far, we've seen 500 patients, and research has shown that they actually recover faster at home. So not only are they in familiar surroundings with their loved ones, they actually recover faster as well. And I just want to talk a little bit. So at the beginning of my presentation, I talked about how, the start of the pandemic was also kind of like the start of digital health in Singapore. So I'm just going to show you this photo right here, the middle photo here, was actually one of the first nationwide pushes of telemedicine in Singapore. And so this was when, I think the first outbreak of COVID in Singapore happened in the migrant workers' dormitories. And because COVID was, so easily transmitted, they were trying to find ways to handle before the Singapore healthcare systems were actually overwhelmed. And so this was one of the first pushes by the ministries, in telemedicine. And we started with nurses over here. So we see nurses, and the nurses are doing the triage, and then they're talking to doctors. And so this is kind of like the beginning of clinical programs, because the nurses would see the same patients and they will flag up, hey, this patient's not doing well, he was better yesterday, he's deteriorating. Doctors who were working day on day, they were noticing that patients who were above 40 were actually performing worse. And so that was kind of like the start of telemedicine and home recovery program and other digital healthcare programs that were supported by the ministry and healthcare system in Singapore. And so we do have quite a bit of support. So in Singapore, we work with some of the major hospitals. Overseas, our major partners are mostly the insurance. And that's because we've spotted that healthcare spend actually decreases when we're using decentralized technology. Okay, so I think this is my last slide, and I just want to share with you a successful test bed that we did. And so when we talk about virtual hospitals, we talk about, hospital without walls. And I think it came to our attention, I think in June, July last year, where in the middle of the Delta wave, India was actually facing quite a difficult time. So what happened was that, there was a widespread COVID crisis in India. A lot of people were actually passing away. And the stories that we heard from people that we knew was that they weren't able to find medical care because the clinics, the hospitals were so full. And what was happening was that the laboratories there were so clogged up that even if you swabbed, they couldn't process it in time before the sample actually deteriorated. So you couldn't get a COVID diagnosis, and because you couldn't get a COVID diagnosis, you couldn't get better, you couldn't get medical care because you were not on the priority list. And so we thought to ourselves, right, we're trying to pioneer this thing called virtual hospital, how do we help? And so we talked to our doctors that we worked with, we found a few of them who were actually licensed to practice in India. And we actually set up a COVID management clinical program for that. And one of our patients actually was diagnosed with COVID by us. He actually was under our care for the whole of his isolation. We managed to contact X-ray centers to do a lung X-ray on him. And we actually nursed him back to health, and he's actually a fully functioning member of society. And he, despite not being able to seek medical care in India, he was actually able to seek medical care abroad in a safe and a controlled manner. And I would consider this a successful test bed of the virtual hospital that we're trying to pioneer. And my last slide is just to show you that we are trying to focus on Southeast Asia and try to do decentralized healthcare and provide healthcare for the whole region of Southeast Asia. All right, thank you.
So now I'll invite all the speakers on site to maybe join me with the at the panel discussion here. Profi, Sarita also, and Kenneth. So what we're going to do next is that we're going to pose some questions to the speakers, and of course the other speakers can also join in. And we also have online our other two speakers, Sven and Alan as well. Can I control the screen? So for those who have questions, you can still post your questions or you can put it online. Let me start off with the questions for Prof. Lee and also for Alan. Basically, what I want to so-called understand more is that although we are in the process of trying to resolve a lot of COVID issue, coming up with solutions like what some of those that we have heard before, but I believe on the other hand, we have actually generated some other problems which wasn't a problem before COVID. So some example could be medical waste. Due to COVID, we are putting up a lot of masks, wearing a lot of gloves, right? And then the other one, like what Alan has actually shared with us, the elective care sometimes could be really pushed aside and the work could be accumulating, right? So just to hear from both of you, being the healthcare authority and also the provider, what are some of these very urgent new problems that have been created while we are trying to solve the COVID issue? What are some of these, so that I hope the audience and those attending online can get a gist of it, because these are most of the time, I believe, outside from the public, which only the operators will know. Then by sharing it, I hope the industry can come together and look for a solution. Maybe I'll start with Prof. Lee.
Okay, but Alan address it first. Alan, you understand? Okay, never mind. I think the key issue that I see is the issue of sustainability, and sustainability in various areas. So, for example, you mentioned waste is one area of sustainability, because we are talking about reducing our carbon footprint, reducing waste and those things. But agree with you, because of infection control and things like that, we have actually generated more consumables, and how do we dispose of them? The next area of sustainability is sustainability of our staff. How do we actually, because staff are working long hours, and it's not just the hours, but it's also the emotional, it can be very taxing. And also, how do we enable our staff to encourage them, to enable them, and to have the sustainability? And the other aspect is, as you mentioned, I think the elective procedures. And when we say elective, quite a number of the procedures are not really elective. They are elective at this point in time, but if certain procedures are sometimes delayed, they become now semi-urgent and things like that. So how do we sustain the care on an ongoing basis? So I will see that under this broad rubric of sustainability as one of the key challenges for our staff, for our patients, as well as for our environment.
Yeah, thank you, Prof. Exactly what you say. Here we are working very hard to be green. on the other hand, we are generating a lot of waste. Yeah, then back to Dr. Allen, how about you?
Yeah, sure. No, this is an excellent and very timely question. So we already mentioned backlog of demand for non-acute services that need to be dealt with. And I think this ties in with the increased inequalities that you often risk seeing in the face of a crisis. So inequalities in terms of health or in general. So the World Health Organization has pointed out that we should take the opportunity provided by the pandemic to try to rebuild our societies and healthcare services in a more equitable and sustainable way. And I think one important development here would be to not fall back into the old habits to take advantage of the new ways of working, which have actually arisen or taken a stronger foothold during the pandemic. So in Norway, we measure national CO2 emissions from the hospital sector. And actually in 2020, for the first time, emissions decreased, which was in part due to reduced travels by staff. The other reason was that temperatures had risen, so there was a less need for heating. But you know, travel is an important area to look into because we have actually managed to change some habits. Obviously, there is a lot of scope for innovation when it comes to reduce resource use and waste. I know Oslo University Hospital is specifically looking at how they can reduce CO2 emissions relating to disposable glove use. So when they look at the whole sort of chain from purchases to point of use by staff, they estimate that they would be able to reduce emissions by around 50%. So I think we sort of need to look at all pathways, you know, and the entirety of pathways to try and lean them in terms of making our services more sustainable.
Thank you. So the next question I would like to pose to Sven, in the sense that roommate, I believe everybody has seen it. There is a very interesting product. In fact, I remember when I was with the hospitals, we're looking at improving the medical devices, moving from a box into a disposable or wearable. But I believe the so-called contactless will be the future. So Sven, did you see the increase in roommate solution ramp up since the start of COVID?
Yes, thank you, Nicker. Yes, we have seen that there has been quite new areas that hospitals and care homes and home care services has seen to expand roommate into to be able to handle the increased workload during the pandemic. So we have seen increased use, like I told you, from hospitals where they can care for more patients than they did before without having to have a personal contact with them, which is also benefits the patient. So we have seen huge improvement or huge increase in demand for our service during the COVID.
Yeah, so one of the questions posed was that actually, can we actually use such a system in the home? I think that would be very interesting for Serene, where she's providing that home H ward, yeah. So I think that kind of devices will be very helpful for her to manage a much bigger population care. So does this system is it able to be expand beyond a care facility back into the home? It is much simpler without much technology.
Absolutely. A roommate solution is in use in many local communities in the Scandinavias, in people's homes. And what it does also is that it makes it easier for the local community to take patients home from the hospital and give them a very good support in their own home much quicker than they otherwise would be able to. So this is something that we particularly see from all those municipalities that use roommate for home care as well.
Yeah, then my next question will be back to the healthcare provider. If we're going to do that, who is going to pay for it properly? If we are able to provide such a solution where we can have really such a service in the community, who do you think could be the payer then?
Was that for me?
No, that's for.
Sorry.
That's a tough question.
Yeah, it's a tough question because I think that I think this I must say I don't have the answer at the moment because it is a certain technology, because even when it is in the hospital, it doesn't mean that there is it would have been included in the cost in some way. So when they are out in the community, then the cost has to be, in a sense, covered in some way. But we also recognize the importance of not creating an unfavorable gradient such that it is cheaper to be, in a sense, to be admitted rather to be at home. So I think a lot depends on the cost benefit analysis of how much the technology costs, what's the savings that would come from it, and then I think we have to work that part out. So I don't have the.
So if Singapore haven't got the answer yet, I wonder whether Norway has something in mind, or have that crossed the mind of the Norwegian healthcare industry. Alan, is there do you have a suggestion of who could be the payer for such a initiative?
Yeah, I'm sure there are others who could contribute as well, and I'm not sure if there's a generic answer to this, but in addition to the good response we already had, I think it's important to also consider unintended gradients in terms of which parts of society can benefit from new technology, so we can avoid having, so that people who are wealthy or well off will be able to use healthcare services which should be made more generally available. So clearly we want to have an uptake of those services that are effective in as big a part of the population as possible. So that would have to be an important consideration.
Yeah, great. Yeah, later in my closing remarks, maybe I have some suggestion that could be possible for Singapore in a certain manner. But let's move on to Kenneth then. Kenneth actually mentioned a very interesting consortium that he highlighted. Of course, more is to be disclosed later. But I'd like to understand from Kenneth, what is your view on learning and development growth beyond staff? Because Ladell has always been in the area of training staff, but of course they do have systems which are reaching out to the public, like in Singapore we have this software called the CRP, what do you call it? The
Responder.
Yeah, the Responder. Yes, that is, I think, a very successful project, Responder, which is actually implemented in Singapore, where the general public can actually have access to CPR devices in the common space. So beyond that, I think with that experience, do you see the learning and development system that you have as again expanding beyond staff to the population in terms of empowerment?
I'll say definitely, because it is skill sets. I'll say in every roles in this community is all about skill sets. And the other thing closely related to skill sets is about the competency. How well can you perform that particular skills is the key. So having these systems, it makes everything trackable. It is transparent, and you know where you are at certain skills or even levels. So I'll say that it is not just being there, attending the course and your whole knowledge journey and things like that. So it's a continuous journey for you to track your competency, upskilling, and then moving to the whole committee level.
Yeah, they remind me of my nurse manager who actually came to me and said, oh, she's spending so many hours in doing the e-competency in that sense. They are still on paper and pen, and it's really taking up a lot of their precious time trying to manage that, and it's quite complicated. So in that case, properly, do you agree with Kenneth in a sense of beyond hospital to community, one of the key components, do you see that as the education part of the population?
Yeah, I certainly see that, as I shared in my presentation, that the community and the population plays a very important role, because health is our own responsibility. As healthcare providers, our job is to enable them and to empower us to be able to take care of our own health where possible. But there will be a certain subgroup that need more assistance, and for those we should extend the necessary. But for a significant number of them, they can actually manage very well with the relevant information, with the relevant skills enabling and those things. So how do we actually enable them? And because my vision is that as we go forward, we should see the residents and the populations as part of the healthcare team. It is not about us and them. It's about all of us working together. So like the example that I shared about the rehabilitation at home, the therapist can equip you and tell you how it's to be done, but you have to have the motivation to do it. You have to have the discipline to do it at a regular time. And so it is about all parties working together as part of the same care team to achieve a common goal.
Yeah, remember you emphasized it's the first line of defense, right? In terms of that being effective. Yeah. Then for Alan, do you see in Norway, do you see that movement of from hospital to community, which I believe you have shared part of that as well? Do you see education as being one of the key components?
Liv Heidi, if you're here, do you want to respond to this question? If so, please feel free.
Yes, I can do that. Thank you for a nice webinar, and Nick here for your question. Yes, we can see a change, and our government wants us to do some projects now that we're trying out to do the care or the treatment, not in hospitals anymore, but in the patient's own home. Through digital care, and we have a lot of experience also now during the pandemic in this remote care. So this is something that we're going to work a lot more with in the next few years.
Yeah, I remember that I just saw your LinkedIn post, which you share one of very successful story where you have this care at home. I think that's very fantastic. For those who are interested, please go into Liv Heidi LinkedIn and you'll see the post there as well. In fact, I think I like it, so you can come to my LinkedIn, you can see that as well. So maybe let's move on to Serene. I think Serene has been very, very busy recently. I would like to understand a bit more, how did MOH collaborate with digital health services like yours to augment the healthcare facility? I think your company has really come in time for such a augmentation of the healthcare services.
I think we work with MOH in a few different phases, and I think the first phase I did touch upon in my presentation was that they did see the change in medical services that the community wanted to provide, and that's where they discussed licensing and policy. And then for those of you who don't know, MOH actually opened this thing called the sandbox, where telemedicine players or digital health players could go in. And because there was no law governing digital health, we were bound by contracts, and we were bound by the contract to perform certain things in certain ways and to keep the patient safe. So that was the second phase. And I think we've come to the third phase, when we're working with MOH. And that's when we start working with the MOH Transformation Office, which is in charge of looking at healthcare 5 years down the road, 10 years down the road. What are the needs and how do we start the foundations of that today? And so we work with the Transformation Office, and I think some of you might have seen on news something called the COVID virtual ward. And that's, joint discussion, joint effort by the ministry in terms of policy, in terms of subsidies, in terms of funding, together with the hospitals, together with us as a clinical partner, and how to provide healthcare safely at home. And healthcare at home is just a subset of digital health in general. And I think, the Transformation Office and various policymakers will continue to see what adds value and what doesn't add value, and how we're going to progress down the road.
Thank you, Serene. So, Prof, back to you again. So, such additional services is coming onto the industry, and with your planning of the new hospital and the new care system that you're planning to bring ahead, I think it'll be very exciting. It'll be very different from the traditional or the existing care services. But how do you actually partner with players like them in a sense of providing the additional services?
I think we are already, as you can see from the logos down there.
Actually, Prof Lee was one of our biggest supporters when we first started. Prof Lee was one of the first believers in digital health. I think his team launched the GP First system. And he actually accepted us as a digital health provider when all the rest were just clinical.
So it's already happening.
Actually, he's one of our biggest supporters.
Yeah, because we had a GP First program where we wanted to encourage our patients to see that if it's a real emergency, you had a heart attack, you have a stroke, you come straight to the emergency department. But if you have symptoms that you're not sure, do you need to go to the A&E? Say, why not you go to the GP first and see your GP? And when you come to the hospital, if the GP feels that you still need, when you come to the hospital, then in our emergency department, you get a $50 discount. And you also get fast track to get that. So that's the incentive there. So initially, when we first started, it was with the physical clinics. Then spoke to your co-founder, and we said, yeah, if it is already, because it comes under the MOH regulatory sandbox, so there's already a framework to for the quality and assurance and all those things. So we said, why not? You know, that if the care, similar care can be provided. So it's working on principles rather than just working on premises per se. So that's why we say it's fine as long as you see a GP who can be physical, or it can be virtual, or can be hybrid, or whatever. So that's how we thought. So I think what we needed to do was to start by boiling it down to the principles of what we are trying to do. Like I shared earlier, it's about the assumptions that we have and what really are we trying to achieve. And if it ticks the relevant requirements, then
that's great.
It cannot work. Yeah.
So at least, yeah. So we are seeing partnership between the care provider and also the committee in that sense, and of course the other service provider. So we are running out of time, but I would like to wrap up with a closing message. Maybe I have the Elvin, can I have the slides? So the speakers can feel free to sit around, or you can move back to your chair. Thank you, everyone. Yeah. So in closing, I just want to summarize or maybe have a few pointers to share. So incidentally, actually the speakers did not get to see their own slides, but you notice that at the very beginning, our ambassador mentioned about this words from Albert Einstein: in the midst of every crisis lies great opportunity. And actually probably also mentioned out of adversity comes opportunity. Basically, they are the same, but it is spoken by two great men. Later, I'm going to tell you another one that has actually shared the same idea. So humans, I would say, are very resilient, right? I trust we have actually managed the situation well and emerged stronger and better. So we used to say healthcare is a very, very slow industry, probably because we find that we need to be extra careful because of patient safety. But actually, if you look at it like what Serene had mentioned, telemedicine, when I was in the industry for 15 years ago, we talked about telemedicine, but the pickup has been very slow generally because the trust and confidence in physical consultation is still there, you see. So people are not so comfortable with telemedicine because they find that they are shortchanged, they feel that they are not confident if they don't do a physical consultation. But can you imagine, in COVID, in 2 years, we actually escalate, and Serene and the team has been working very hard because of that high increase in demand. And another case will be the hand hygiene, right? We always have a lot of challenges with, probably I believe will agree, in hand hygiene compliance within the hospital. I was at one time the hand hygiene auditor as well. When I'm there, everybody will wash their hands very nicely, but if I'm not there, they won't do it. So hand hygiene has been a problem for many years, and that actually has caused a lot of infection control issues. But can you imagine again, within 2 years, I won't even mention the staff. The staff all have been diligently doing their hand hygiene. On top of that, the population, the general public are able to do the 7 steps. They are also using the hand sanitizer very regularly. Actually, one question I have, probably we won't answer now, but I'll post it to probably and those online who are healthcare providers. With this increase in observation or compliance with hand hygiene, has infection cases in hospital actually decreased? Right? That's an interesting question. Right? So, Elvin? So the third person I mentioned the same thing is actually by John F. Kennedy. He said, if you look at the Chinese character, for those who understand Chinese, I all will understand that. When written in Chinese, the word crisis, which is called 危机, okay, 危 actually means 危险, that means it's danger. 机 is opportunity. So again, you can see in these three wise words from the three great men. When there is a crisis or when there are challenges, there is always new opportunities, which we are seeing in COVID, right? Then, when there's no crisis, does it mean there's no opportunity? I want to highlight this point because there's good news, right? Good news in Singapore, which was shared on the 9th of March, which is actually last week, which I believe will incentivize a long-awaited important major shift of our healthcare services. So what is this important news? I would like to share with everybody because I find, again, other than crisis, this is going to bring us a big change, a big shift in our healthcare system in Singapore. So what has changed is from FFS, which we call fee for service, to capitation. Okay, what is this about? I remember back in about this news cutting from 2019. In fact, it goes beyond before 2019. We talk about a value-based system where healthcare providers are accountable for outcomes that will benefit patients. And I believe this derived from a concept of beyond quality to value, system that focus on the delivery of healthcare rather than healthcare services. Because Singapore system all along has been on FFS. That means you get a service, you get a fee. But what happened on the 9th of March, it was publicly announced. In fact, we who are in the healthcare industry know that this is coming, but it was a long-awaited one. So this is the good news from FFS to capitation. So instead of getting paid for each doctor visit and medical procedure, Singapore 3 public healthcare cluster will start getting a fixed sum of money for every person living in the area under their care, under their charge. This means hospitals have a fresh incentive because before that it has been challenging in terms of preventive care. Because again, I asked the question, where does the money come from? So that was one of the questions which I posted just now. I hope maybe the way to increase the community care facility or ability could be actually coming from this funding. I don't know. Or we probably will be able to answer that in future. So last but not least, okay, after sharing that good new opportunity, I believe there will be a lot of activities coming. So for those online, if you have a solution which are helping us to manage the community or providing a better care in the community, please get in contact with me. But I'd like to send our greater appreciation and gratitude to the speakers for spending their time today. And for Norwegian solution providers who are online, if you'd like to know more about TECHLAB or about the market expansion, please contact me. Similarly, for those healthcare providers listening in, if you have any product or services that you are interested in, you may actually look for me as well. Okay. In any case, anything about this, or you want to have more information about today's session, this is my email. Please contact me. So with that, I will end off with what is coming up on these same premises. On the 23rd of March, we have another event called the Circular Economy Seminar, utilizing seafood side products. So if you're keen, please Google this. We will actually get to see the registration page as well. On the 29th of March, we will have a sharing session on maritime technology and innovation, which is digitalization and decarbonization. Right. If you have any healthcare topics which are of interest to you, please write to me. So with that, I end the session today. Thank you, everybody.